Hey everyone, welcome back to my channel. If you're new here, I'm Dr. Adilo, and on this channel we break down complex brain and nervous system topics in a way that's clear, clinically relevant and actually useful. We are wrapping up our Stroke in Children series today, part 4. If you haven't watched parts 1 through 3 yet, I've linked them in the description. We've covered hemorrhagic stroke, arterial ischemic stroke and cerebral sinovenous thrombosis. Today, we're talking about something a little different, vascular lesions in the spinal cord. And next time, we are going into stroke mimics. So, stay tuned for that. Let's get into it. When we talk about stroke in children, we tend to focus on the brain. But the spinal cord has its own blood supply, and vascular events can happen here too. Most children who present with acute spinal cord symptoms, sudden weakness in the legs, sensory changes, urinary problems, turn out to have transverse myelitis, which is usually post-infectious or linked to demyelinating conditions like multiple sclerosis or neuromyelitis optica. But in a small proportion of these kids, the cause is actually vascular, meaning the spinal cord is being damaged due to infarction, ischemia or hemorrhage, not inflammation. Clinically, the two can look very similar at first. That's what makes this topic so important to understand. Who gets spinal cord vascular disease? So, there are two main vascular categories to know. Number 1, Vasculitic processes, most commonly associated with systemic lupus erythematosus, SLE. Number 2, embolic events, including Fibrocartilaginous embolism, where nucleus pulposus material gets into the spinal cord vasculature. Embolism from vertebral artery dissection, embolism from aortic dissection at the artery of Adamkiewicz. And rarely, arteriovenous malformations of the spinal cord can cause myelopathy and hemorrhage. We should always have this on our radar. Let's talk about SLE myelitis first, because this one has some really important pearls. Most SLE-associated myelitis is longitudinally extensive, meaning the lesion spans multiple spinal cord segments on MRI. Here's the clinical pearl most people miss. In 23 to 60% of cases, spinal cord involvement can be the first manifestation of lupus. The child may not yet carry a lupus diagnosis, and it often occurs at time of low systemic disease activity. So, you can't use "she's not in the lupus flare" to rule this out. The prognosis is sobering. Only 14% of children experience complete recovery. This is why early recognition and treatment matters so much. Other vasculitic causes to keep in mind in children include Behçet's disease. Now, embolic causes. Fibrocartilaginous embolism. This is a fascinating and under-recognized entity. Nucleus pulposus material from an intervertebral disc somehow embolizes into the spinal vasculature, causing cord infarction. It can happen anywhere in the spinal cord and is associated with hyperacute onset. Vertebral artery dissection causes ischemic myelopathy in the cervical spine specifically. When you see a cervical cord lesion, less posterior circulation brain ischemia on imaging, think vertebral artery dissection. Always image the head and neck vessels. Aortic dissection can compromise the artery of Adamkiewicz, the dominant radicular artery supplying the lower thoracic and lumbar cord, causing anterior cord syndrome. A key distinguishing feature from inflammatory transverse myelitis, hyperacute onset, symptoms progressing over minutes, not hours to days. And on MRI, a wedge-shaped lesion with diffusion restriction on DWI points strongly towards ischemia. Now, whether the cause is vasculitic or embolic, the clinical presentation is actually quite similar to the inflammatory transverse myelitis. Acute onset motor weakness progressing over minutes to hours. Sensory abnormalities, a sensory level distal to the lesion. Back or neck pain depending on the level of the lesion. Early areflexia reflecting spinal shock. Urinary retention, a very frequent symptom. Don't miss it. Then in the weeks that follow, as spinal shock resolves, you see spasticity, hyperreflexia and clonus emerge. The speed of progression and the pain at onset are both important clues pointing towards a vascular etiology rather than inflammation. Your first line investigation is MRI of the spinal cord, both cervical and thoracic, because longitudinally extensive lesions are common in pediatric populations. What sequences do you need? T1 and T2, sagittal and axial, with gadolinium gradient echo, GRE. Sensitive for hemorrhage, DWI, that is diffusion weighted imaging, diffusion restriction point towards ischemia. Also do a brain MRI with vascular imaging of the head and neck vessels. This can help identify large vessel disease, vertebral artery dissection or coexisting intracranial pathology. For lumbar puncture, always do your MRI first to rule out a complete spinal block. Once that's cleared, inflammatory transverse myelitis, elevated WBCs and protein. Embolic or ischemic myelopathy, CSF is usually normal, there is no pleocytosis. SLE myelitis can have elevated WBCs and protein. For the blood work, do a rheumatologic workup, ANA, anti-dsDNA, complement levels, ANCA level. Hypercoagulable state workup if ischemic etiology is suspected. Antiphospholipid antibodies, particularly relevant in SLE. Now let's come to the treatment. Treatment is directed at the underlying cause. For SLE myelitis, immunosuppression, typically high-dose corticosteroids and often followed by long-term disease-modifying therapy. Given the poor recovery rates, prophylactic treatment is strongly recommended once the diagnosis is established. For ischemic or embolic myelopathy, low-dose aspirin, that is 2 to 4 mg per kg per day, may be indicated for secondary prevention. For vascular malformations, neurosurgical or endovascular intervention may be needed. And regardless of the underlying cause, supportive care is a massive part of management. Neuropathic pain management, spasticity management, baclofen physiotherapy. Urinary symptoms, bladder training, clean intermittent catheterization. Rehab, early physiotherapy and occupational therapy make a real difference in outcomes. Let me leave you with 5 things I want you to walk away with. 1. Vascular myelopathy in children can mimic inflammatory transverse myelitis. Speed of onset and DWI restriction help differentiate. 2. SLE myelitis can be the first presentation of lupus. Always screen for rheumatologic disease in a child with transverse myelitis. 3. Fibrocartilaginous embolism is hyperacute, can occur at any cord level and DWI shows diffusion restriction. 4. Cervical cord lesion plus posterior circulation drain infarct. Think vertebral artery dissection. Image the neck vessels. 5th, recovery from ischemic spinal cord injury is poor. Identify the cause early, start prophylaxis and optimize rehabilitation. And that wraps up our stroke in children series. We've covered arterial ischemic stroke, hemorrhagic stroke, sinovenous thrombosis and spinal cord vascular lesions. Next up, we have stroke mimics. Same clinical presentation, very different diagnosis. That one is going to be a really practical video. If you found this useful, please give it a thumbs up. share it with a colleague, and subscribe so you don't miss the next one. Drop any questions in the comments below. See you next time. Take care everyone. Bye.